Next, we'll look at an important drug group in the treatment of patients with osteoporosis. Bisphosphonates are a relatively new class of drugs and have a lot of members, including pamidronate, alendronate, and others ending in dronate. The idea is that these drugs will inhibit the activity of osteoclasts. What do you think the effect is? Well, that will decrease bone resorption. Clinically, they have been very effective for postmenopausal osteoporosis and have reduced the risk of fractures at multiple sites of the body. These drugs can also be used in other diseases, namely malignancy-associated hypercalcemia and also Paget's disease of the bone. Now, how will these drugs be tested? Well, most likely on the side effects, and the side effects are classic. As with many other drug classes, there are non-specific side effects like nausea and diarrhea. But more importantly, you can see corrosive esophagitis. What should you recommend for these types of patients? The recommendation would be to take the pills around mealtime and also to remain upright for some time after ingestion to help prevent this uncomfortable side effect. What about osteonecrosis of the jaw? Osteonecrosis of the jaw can be a result of bisphosphonate use as well. This is a pretty classic side effect. Okay, check out this complex structure of teriparatide. Don't worry, you don't have to memorize it. I wanted to show it to you because you can identify the carbon-nitrogen backbone, and this is classic for a protein. And that's exactly what teriparatide is. It's the active part of the parathyroid hormone. In fact, only the first 28 residues. So how do you think it works? Well, it's given in a pulsatile fashion once daily subcutaneously. While continuous PTH causes bone to melt away like we see in hyperparathyroidism, instead this administration actually increases osteoblastic activity and boosts bone density. So what's it used for? Well, usually osteoporosis to increase bone anabolism. Are there any toxicities with this drug? Well, some patients have a transient hypercalcemia, which makes sense for this PTH analog. Some rodent studies have also seen osteosarcoma in their teriparatide-treated groups, but this hasn't borne out in human trials. Okay, before moving on to gout drugs, let's have a flash quiz to jog your memory. How would you definitively diagnose gout? With a joint aspiration that shows negatively birefringent needles. While we did discuss some of the treatment options for gout in the pathology section, we're going to go over them in more detail here. The management of gout is both chronic, or the time in between flares, and acute, when the patient is having actual raging pain. Let's review a little bit about the normal pathway for uric acid metabolism. Now, where do purines come from? Well, they come both from our diet and also from native nucleic acid metabolism. These purines are then broken down by xanthine oxidase, which breaks them down into uric acid. This uric acid goes to the kidney and is dumped into the glomerulus, and reabsorbed from the urine at the proximal tubule. In chronic gout, why is allopurinol effective? Well, it inhibits the action of xanthine oxidase, preventing the formation of uric acid in the first place. This causes decreased serum uric acid levels. As we discussed earlier, oncologists use this drug in leukemia and lymphoma to prevent tumor lysis-associated urate nephropathy. Are there any drugs that utilize xanthine oxidase for metabolism? Yes, think of azathioprine and 6-mercaptopurine. What would happen if you gave these patients allopurinol concurrently? They may have the drug build up to toxic levels. I keep the mechanism of allopurinol straight in my head by remembering that it starts with the letter A for antagonist, which helps you remember that it inhibits xanthine oxidase enzymes. There's now a new drug, just like allopurinol, called febuxostat. Now, how does this work? Well, it also inhibits xanthine oxidase. Would you expect it to have the same drug interactions? Yes, because it'll still block the metabolism of 6-mercaptopurine and azathioprine. Now, pegloticase is a very interesting drug because it's a recombinant gene that we lost during evolution over the eons. It's a recombinant uricase, and it metabolizes uric acid into a more water-soluble product, allantoin. Animals still have this gene, and there are a lot of theories out there about why humans lost uricase throughout the course of evolution. Probenecid, the other option for treatment of chronic gout, works by blocking the reabsorption of uric acid at the proximal tubule. Now, what does that mean for uric acid in the kidney? Well, more will pass out in the urine. Interestingly, probenecid also has the side effect of inhibiting the secretion of penicillin, something to be aware of if the patient is on penicillin and on probenecid at the same time. What will happen to penicillin in this situation? Well, it'll have higher serum concentrations. The way I like to remember probenecid's mechanism is to remember it starts with the letter P, and it's reduced uric acid levels by making you pee out uric acid, and blocks penicillin. Okay, colchicine is a drug that is used in acute gout along with NSAID therapy. The idea is that they bind to and stabilize tubulin in microtubules, which decreases polymerization. How does this work out for gout patients? Well, it helps prevent leukocyte chemotaxis, meaning that leukocytes have difficulty getting to the site of inflammation and inadvertently causing more damage. As a side note, remember that certain chemotherapy drugs also work by altering microtubule function, such as vincristine and vinblastine. The problem with these drugs, despite their efficacy, is that they have awful GI side effects, especially when taken orally. The reason NSAIDs are often used instead is because they have more tolerable side effects. Glucocorticoids, either oral or intra-articular, are also used for acute gout attacks. Now, no one really knows if steroids even really work for gout. There haven't been any good trials. However, if a patient fails on NSAIDs and colchicine, try them with good old steroids. What should you avoid giving in an acute gout flare? Well, any salicylate. They actually depress uric acid clearance until you get up to 5 to 6 grams a day, and even these high doses have minor clearance activity. Flash quiz. Does rheumatoid arthritis improve with activity? Yes, and running stiff joints under warm water. Osteoarthritis improves with rest. The final drug class that will be discussed in this chapter is the TNF-alpha inhibitors. There are 3 of them that you need to know: etanercept, infliximab, and adalimumab. Now, how do they work? Well, they all block the function of TNF-alpha, but do so differently. Etanercept is a decoy receptor that binds to soluble TNF-alpha. You can remember this by remembering that etanercept is a decoy receptor for TNF. What about infliximab and adalimumab? As you can tell from the ab ending, they are actually antibodies. Their antigen is the TNF molecule. Etanercept and adalimumab have the same indications, including rheumatoid arthritis, psoriasis, and ankylosing spondylitis. Infliximab only differs in that it's not approved for the use of psoriasis. Now, which of these drugs, etanercept, infliximab, and adalimumab, may be used for Crohn's disease treatment? Good, only infliximab. Now, as you may remember from earlier chapters, the toxicity of TNF-alpha inhibitors is that they may predispose to infections because they're modulating an important part of the immune system. So, before starting therapy, what must you do? You need to get a PPD test to test for latent tuberculosis. A cool fact is that TNF actually is important in the granuloma formation and stabilization, so blocking it can reactivate the disease. Thinking about TB and placing a PPD test before starting a TNF-alpha inhibitor will show up on your step 1, so please don't miss this. The last drug, rasburicase, is a recombinant uricase that catalyzes the metabolism of uric acid to allantoin. A very common and high-yield clinical use for this drug is for the prevention and treatment of tumor lysis syndrome. Now quickly, how might tumor lysis syndrome present on an EKG? Correct, peaked T waves. All that potassium is being released from dying cells into the circulation. If you see this EKG on an exam and they ask you how to prevent this situation with medication, don't forget about resburicase. Alright, let's do some practice questions. A 27-year-old man comes to the physician's office with a 6-month history of low back pain and stiffness that wakes him during the night and is worse in the morning. The patient was diagnosed with bilateral sacroiliitis 4 months ago because of his tenderness to percussion of the sacroiliac joints and pain on the springing of the pelvis. He has some limitation of motion of his lumbar spine. Laboratory tests are most likely to be positive for which of the following? The answer is A, HLA-B27. This patient has ankylosing spondylitis, a chronic inflammatory disease of the spine and sacroiliac joints that often leads to the stiffening or consolidation of the bones that make up those joints. Common findings are low back pain, stiffness for over 3 months, pain and stiffness in the thoracic region, limited movement in the lumbar area, and limited chest expansion. Around 90% of patients are positive for the HLA-B27. And common complications include uveitis and aortic regurgitation. Next, a 17-year-old girl complains of a painful, swollen left elbow and fever. In the previous days, her right knee was also swollen and slightly painful. Physical examination is notable for several oral ulcers and an edematous and tender left elbow. Laboratory tests reveal anemia and weakly positive anti-nuclear antibodies, and the results of the VDRL testing are positive. The patient is shocked when informed of her positive result for syphilis, stating that she has no sexual history. Which of the following is the most specific antibody for this patient's condition? The answer is E, anti-Smith antibodies. This patient has findings suggestive of lupus, arthritis, oral ulcers, fever, anemia, and positive anti-nuclear antibodies. As is the case with many lupus patients, this woman probably has antiphospholipid antibodies as well. These autoantibodies react to the cardiolipin antigen used in the syphilis serology, thus giving a false positive result for syphilis. Anti-nuclear antibodies are sensitive for lupus, but anti-Smith and anti-double-stranded DNA antibodies are the most specific markers for the disease. Alright guys, that wraps up pharmacology. I'll see you next time.